صار؟
طيب السلام عليكم ورحمة الله وبركاته. I think we can start. My name is Wael Alqarawy. I'm an electrophysiologist at King Khalid University Hospital. We're going to talk today about devices, pacemakers, and ICDs. You guys can see slides, right?
Yes, Prof.
Excellent. So devices can be a bit intimidating and complicated. What I thought we can do is just talk about what I thought are basics for general cardiologists. So what are the things you need to know about devices, implant, programming, complications, preoperative management. Some of what I'm going to talk about might be quite basic for some of you. Some might be a bit complicated, but I think at least if you know most of what I'm going to talk about, you should be okay when it comes to devices. It's a small group, so please stop me at any time if you have any questions or here. Okay. All right. So first, we're just going to go through implant overview. So most of the time, when it comes to pacemakers, we implant either dual chamber pacemakers, so one lead in the and one lead in the right ventricle. This is how it looks like inside the heart. The right atrium goes to the right atrial lead goes to the right atrial appendage. And then we fix it in the appendage. That's why it has this U shape. You see it here, and you see it on X-ray. Typically, the RV lead goes to the RV apex. See it here. This is the most common location. Sometimes we implant a left ventricular lead. So this goes through the coronary sinus into one of the branches of the coronary sinus. So again, this is the RA lead in the right atrial appendage. This is the RV lead in the RV apex. And this is the LV lead, or coronary sinus lead. Typically, the implant, we implant from the left side unless there is a problem, infection, or dialysis line, or occlusion of the vein. But most of the time, we implant devices from the left side. We use the subclavian vein to access the heart. So we access the vein, put the leads, and then position them accordingly. And as I said, the way we go to the left is by using the coronary sinus. Okay, next is the terminology we use. So you guys hear things like VVI pacemaker, AAI, or DDD. This is how we describe pacemakers, and there's a system for that. This system uses 5 letters. First letter refers to the chamber we're pacing. So if we're pacing the ventricle, it's V, ventricle. If we're pacing atrium, it's A. If we're pacing both, it's D. Okay. Second letter refers to the chamber we're sensing. So if we're sensing the ventricle to pace the ventricle, it will be VV. And so on. It will be more clear when I'm done, but let's just go through what each letter means. Third is the response to the sensed event. So when the device senses an intrinsic activity, what does it do? Does it trigger pacing event, or does it inhibit, or does it do both? Or is it just not watching, which is O? So I means inhibit. When it senses something, it asks the device not to pace. T, it means if it senses an event, it asks the device to pace. O, it's just not watching. D, dual, it means it does both. The fourth letter refers to the rate modulation, which means rate response. Our sinus node, when we exercise, the heart rate goes up. When you sleep, it goes down. So it goes up and down depending on the need. We can program the device to pace at the fixed rate. So we ask the device to pace, let's say, at 50. So if we exercise or sleep or run, it will just keep pacing at 50. But this is not ideal because, if the patient starts running, they'll need heart rate faster than 50. So there's something called rate response, rate modulation. It senses the increase in respiration, changes in the muscle movement of the chest, and then that leads to increasing the rate. So this is called rate response. Fifth letter, which we don't use often, is when we have a lead that paces at multiple sites. So for now, I think you can just ignore this. This is not really a common thing. So these are the most common programming settings that we use. Let's go through them. So the easiest one is VVI. So what does that mean? First letter is the chamber paced. So we're pacing the ventricle. Second, we're sensing the ventricle. I, if anything is sensed in the ventricle, the pacemaker is not going to be paced. That's why it's I, VVI. So this is what we use for single chamber pacemaker. We have only one lead, so we're pacing and sensing from the same ventricle. And we're asking the device if the patient has a heart rate faster than our set rate, not to pace, because the pacemaker is just a backup. And then if we add R to it, so VVIR, it means that we're asking the pacemaker if it senses that the patient is doing any activity to increase the rate. Okay, so this is VVI, VVIR. Next common is DDD. So first letter D, it means we're pacing both the atrium and the ventricle. So immediately you know this patient has two leads, one in the atrium, one in the ventricle. The second D is we're sensing both atrium and ventricle. Third D is we're both inhibiting and triggering. So inhibiting is easy. If the patient has, let's say we're setting the rate at 50 beats per minute, and the patient has a sinus rate of 40 beats per minute. It means that the atrial lead will pace because the intrinsic rate is lower than the set rate. We'll pace in the atrium and we'll pace in the ventricle. Yeah, but trigger means it will pace the atrium, and then this pacing in the atrium will trigger the ventricle to pace after a certain period of time, which is similar to the PR for the intrinsic rhythm. The ventricle will know, to coordinate, will know when the atrial is being paced, to wait the PR interval and then pace the ventricle. That's why the third letter is D. And then if we do DDDR, again, it just means that we're asking the pacemaker to increase the rate when needed. Okay. Any questions? This can be confusing. Any questions so far about the technology? Okay.
Doctor, excuse me. Yeah, I have a question. Yeah. Regarding this one, it means inhibit. So it means if the device sensed any intrinsic activity for the patient, it will inhibit any pacing rhythm from the device?
Exactly. That's it. Yeah.
But what about the T? It's normal to the physiological one. It's mean just we are trigger the atrium trigger the ventricle with a normal with similar to the physiological one.
Exactly. Yeah, exactly. Trigger. So there's also a question from Nasser to repeat the trigger. So trigger, it means that I want to coordinate between the atrium and ventricle. So I want the atrial pace to trigger ventricular pace after a certain period that I determine. عشان ما يكون الديفايس pacing atrium or ventricle كده without coordination. I want when the atrial is paced, the device waits and then pace the ventricle. Good. Any questions?
Yes, salam alaikum.
Salam.
Regarding the DDD,
Yeah.
so can you kindly just repeat it, how the last D is, how the device will regulate the inhibitory and trigger effect?
Yeah, sure. So the last D means dual. So it does inhibit when it senses, but also trigger. So let's take how it inhibits. You have a dual chamber pacemaker, one lead in the atrium, one lead in the ventricle. You set the rate, let's say at 50. So you're asking the pacemaker to pace if the rate is anything lower than 50. The pacemaker will wait. If the patient has a sinus rate of 60, the atrial lead will sense this atrial activity and will inhibit pacing. There's no need for pacing because the rate is more than 50. So this is the I part of the dual. And then let's say the rate goes down now to 30. So the atrial lead is not sensing anything. So it says, okay, I need to pace. So it paces the atrium. And this pacing triggers the ventricular pacing after a certain period of time. Once you pace the A, it triggers the ventricular pace to say, pace the ventricle after, let's say, 150 milliseconds. So I have A paced, nothing, similar to the PR interval, and then V paced. واضح ولا؟
Yes, thank you.
No problem. Okay. So let me ask you guys a question to see if you truly understood this. So if you have, if I tell you this patient, we program the device to VOO, what does that mean? Only pace. Yeah, exactly. Regardless, pace, continuous, exactly. Excellent. Excellent. Just to make sure everyone got that. So VOO, you go, the first letter is pacing. So we're pacing the ventricle. Are we sensed? But then the second letter is O, so none. Are we sensing anything? No. We're not sensing anything, or there's no response to sensing. It means we're just pacing all the time. So why would you do that? Why would you program someone VOO? OR, yeah, exactly. When you fear that there's something will interfere with the pacemaker and the pacemaker will think that there is activity, مثلا electrocautery. So you want the device not to sense anything. Pacemaker dependent patient, you just say, just pace all the time. Don't look for anything, because I know a patient has no underlying rhythm, and I'm worried that electrocautery will be interpreted as intrinsic rhythm. So I'm just gonna program it as VOO. Good, excellent. Any questions? No, good. Okay, so this is when we implant a single lead in the ventricle. Now, in the past, we used to implant single leads in the atrium, like you see here. We don't do that, at least not commonly anyways, because if you have sinus node disease, you're at risk of developing AV node disease. So might as well just implant either dual or single in the ventricle. But this is how the VVI pacemaker rhythm strip will look like. You'll have a pacing spike, and then QRS. And then if you have intrinsic rhythm, this QRS will be sensed by the device, so it will reset the time it waits until the next pace rhythm. Yeah, so it does two essential functions. Pacemaker, it paces, and this is evidence of pacing, and it senses. How do you know it senses? Because it waits. It senses this and it waits depending on the rate we programmed it at to pace the next beat. This is how AAI, but I wouldn't worry about this. This is really not common nowadays. What about dual chamber pacemakers, which we commonly use? So you'll have one typically in the appendage, one in the RV apex, and you will have two spikes, one for the atrium, one for the ventricle. This delay, this time difference, we call it AV delay, which is equivalent to the PR interval when it's intrinsic rhythm. We set that. And similar to the VVI, you see spike and then P for the atrial lead, spike and QRS for the ventricular. Okay, this is again just to go over really most common nomenclature you're going to see. VVI, we talked about VOO, DDD, and DOO. We didn't talk about DOO. What's DOO? Dual pacing without sensing. Exactly. You set the rate of the atrium, you set the AV delay, you set the ventricular rate, and then you just...
Yeah. Come.
Okay.
Yeah.
If you can mute yourself, I think someone by mistake just unmuted himself. CRT, there are two. What's CRT? Resynchronization therapy, yeah. And what does that mean? How many leads are there? 3. So we have one in the atrium, one in the RV, one in the LV. The goal of that in patients with left bundle branch block to pace the left ventricle and right ventricle at the same time. When you have left bundle branch block, because of the block, the LV contracts later than the RV. We put the lead in the LV, and then we pace both at the same time, which helps with heart failure. Now, this CRT can be pacing only. We only pace, but it can be pacing with ICD function. In that case, we call it CRT-D, cardiac resynchronization therapy with defibrillation. Yeah. Okay, there are a few questions. Let's go back. So when to implant VVI versus DDD? Yeah, that's a good question. So it's really a clinical judgment, but sometimes there are clear answers. So for example, patients with permanent atrial fibrillation, is there a point of implanting an atrial lead? No, they're not going to pace. The atrium is in atrial fibrillation, so you're done. So in these cases, we just implant VVI. If the patient is in sinus rhythm, it really depends if you think they're going to benefit from atrial kick or not. So let's say 90-year-old bedridden patient with heart block, and you're going to implant VI or DDD, probably VVI, because they just need something to prevent asystole, really. But a 40-year-old, well, not 40, 50-year-old post-TAVI with diastolic dysfunction, LVH, high filling pressures, normal EF with heart block, you're probably going to implant dual because you think they will need the atrial. So it's a clinical judgment. Can I ask what's the meaning of sensing? Difference between pacing and sensing. Yeah. So sensing is what the lead is seeing. We'll come back to that in a second, but I'll just briefly discuss it now. So sensing is what is the lead seeing in activity or even external activity like electrocautery. Pacing is the electrical output from the device to capture the myocardium. Okay, and we'll discuss that more in a few minutes. Okay. Oh, there you go. So pacemaker testing. So when we test pacemakers, there are three things that we need to test. We need to test sensing, we need to test pacing, we need to test impedance. And we'll see why these are the three main functions of the pacemaker. So what's sensing? Sensing is the ability of the pacemaker to see when an intrinsic depolarization is occurring. So when we implant the lead, and then there is a sinus speed, this lead will see that. And it can see it very clearly when it's large, or if the lead location is somewhere around scar, let's say, or around the valve, or somewhere where it doesn't really see much, this R wave will be small. And this is what we assess during implant. We want the lead be in a position where if there is any intrinsic activity, we'll see it very clearly. Why is that? Why is that? Because this is what the device is going to use to assess whether it needs to pace or not. So the location of the lead, if you may, is what determines how large the R wave is. But then we set the sensitivity threshold, these numbers. We ask the device to see anything more than 1.2 or 2.5 or 5. We change that number. And think of it as a fence. If we ask the device to see only R waves more than 5, it means it's just not going to see anything. And even if there's intrinsic rhythm, it will think that there's nothing and will just keep pacing. And if we set it too low, we'll say, you know what, anything more than 1.25 millivolt, see it. So it will see many things that might not be R wave. So here, for example, it will see the T wave and it will think that this is R wave and it will inhibit pacing, which is a problem. So it's a balance. This is a perfect sensitivity threshold where we only see R wave, we see it very clearly. So even if it changes a little bit with time, we still have a safety margin. This is what we do in the device clinic. This is what we test and then determine what number is good for that patient. And again, why is that important? Because sensing is what going to determine how long the pacemaker needs to wait before it paces. When it sees this, it will start counting this timing again. If we ask the device to wait 1000 milliseconds before it paces, it will wait, and then sees this, starts counting again until it's 1000 and then paces again. If it didn't see this, it will pace here, which is unneeded. That's why sensing is important. Any question about sensing? Okay. Next is pacing threshold, which means the minimum electrical stimulus needed to capture the myocardium. So you pace here at output, let's say 2, and then you drop it to 1.5, you're still capturing. 1, you're still capturing. 0.5, you lost capture. You have a spike, there's no QRS. So you say, okay, the programming has to be 1 or more. So I know for sure when the pacemaker wants to pace, it will capture the myocardium. Usually we set it higher than the threshold. This is the lower. So for safety, we double it or triple it. And we say, okay, program it at 3. So we know for sure it will capture every time it's needed. What we said, the sensitivity depends on the location of the lead, right? How large does it see? And then we program the threshold. So the threshold for pacing is the same, but why the capture is high or low, there are multiple factors. Some related to the lead itself. There's a fracture in the lead or insulation break, so some mechanical problem with the lead. Or it could be the location where the lead is. If it's attached to scar tissue, it's harder to capture, for example. Or it could be external factors. So some drugs can raise the pacing threshold, electrolyte imbalances, and many other factors. Okay, impedance is the least important when it comes to pacing parameters, but it's something that nice to know. So impedance essentially means resistance. So electricity runs in the lead in a similar way where water, for example, run in a pipe or a hose. So when you have high resistance or high impedance, it means there's something blocking the flow. This could be fracture, for example, in case of lead. There's low resistance or low impedance, it means there is leak of water or leak of electricity in case of insulation. Leads have insulation around them to prevent the electrical current from leaking. So if there's breach of that insulation, the impedance will go low. And then if there's nothing, there's normal impedance. Impedance helps when you have a problem with pacing, for example, and you're not sure. So we said, for example, here that insulation break or fracture can cause the threshold to be high. So how do you know which is which? By looking at the impedance. If you have high pacing threshold and high impedance, you say, okay, this is probably lead fracture. If you have high pacing threshold but low impedance, you say, okay, maybe this is insulation break, and so on. For you, though, the most important thing is that the impedance is stable. There's no acute rise. So you see, if the first page when you interrogate the device will give you the trend for the impedance. Orange is ventricular lead, blue is atrial lead, and you see how they're stable. So you know things are fine. Typically, it ranges between 200 and 1,000. So it's a wide range. That's why looking at trend is helpful. There's an acute rise or drop, then you know something happened around that time. Good. Any questions so far? No, good. So let's look at some X-rays. What type of device is this? Oh, can you repeat threshold? Let's just go back to the threshold. The threshold means what's the minimum output from the device that will capture the myocardium. How do we pace? Device, I need to pace. When تعطي output, electricity. This electricity goes through the lead إلى التب حق الليد and it captures the myocardium. طيب كم الاوتبوت اللي الديفايس يحتاج يطلع مع for each pacing؟ هذا الاوتبوت اللي يحتاجه الديفايس هو الثريشولد. اقل output needed to capture the myocardium we call it pacing threshold. معناته اقل من كذا he will not capture the myocardium. How do we assess that? نروح للبيشنت ونحط الاي سي جي we start pacing and dropping the output ونشوف متى when did we lose out. فهنا مثلا we're pacing at 2 volt capture, yes, 1.5 capture, excellent, 1 capture, 0.5 في spike بس ما في capture. معناه نقول 0.5 didn't capture, the last one captured is 1. So the pacing threshold, أي شيء أقل من 1 will not capture. So I cannot program the device to give less than 1 volt مثلا. فأروح أعطيه 2 ولا 3 احتياط. This is what pacing threshold is. Okay. So let's go back to the X-ray. Yeah, so someone said dual, right? Hassan. Good. You see that, right? And RV. What about this one? Single. Exactly. Excellent. What about this one? It's a trick one. مع إنه في سهم بس. Leadless, yeah. So I just wanted to mention this, not super important, but just so for your knowledge. And nowadays we can actually do pacemakers without leads, leadless pacemaker. You see this device? It has the device itself and the lead, if you like. So it's just one thing. The advantage, you don't need the lead. You don't need venous access other than the femoral. Sometimes both sides are occluded, which is fine for leadless. Less risk of infection because the more surface area of a foreign body you have inside the body, the higher the risk of infection. Disadvantage, it's always, for now anyways, a single lead. So asynchronous pacing means you cannot pace the atrium and ventricle. Also, if there's any issues, you can't retrieve it, although this is changing now. And it's a new thing, so we don't know what's going to happen in 20, 30 years if more complications are going to show up. Okay. So pacemaker malfunction. This is probably the most difficult part, and it can be confusing. So what I thought we could do was just divide them into steps, which will cover most of what you need to know. This can be really complicated, even for senior consultants, because every company has different programming and so on, but the basics are not that different. So what I suggest you do when you think that there is pacemaker malfunction, you ask yourself 2 questions. Is it capturing? And is it sensing? And you should cover most of pacemaker malfunction that way. And then, so is it capturing? If the answer is no, then you go to the next level, which is, are there spikes? يعني هل في spike وما في QRS ولا أصلا ما في spike؟ إذا ما في, there's no spike, معناته the device أصلا is not trying to pace. This will help you in step 3, knowing what's the problem. If في spike but no QRS in cases of ventricular pacing, or P in cases of atrial pacing, معناته it's just failure to capture. The device is actually trying to pace, but failing to capture. Okay. Next question is it sensing? Yani, is it seeing the underlying rhythm? If it's not sensing, this will be evident by overpacing. Yani, if the device is pacing in areas where it shouldn't pace, and في QRS, وبعدين بعده على طول the pacemaker is trying to pace. This is under sensing. It didn't see this QRS. Or is it over sensing? Over sensing, it means it's seeing things that are not there. If a flat line, what device is just, it's not even trying to pace and it thinks there's no need. It's probably seeing something. Okay. I know this is complicated. We'll go back step by step, but just bear with me for now. So the first is it capturing? If you say yes, you're fine. Abdurrahman, capture means impedance. No, impedance, honestly don't impedance. Impedance just helps you know the cause of high pacing threshold. So it's a detail that if you know, nice. If not, don't worry about it. Sensing and threshold are the important ones. Impedance is an extra parameter that helps you know the details of the cause. Okay, so is it capturing? Not capturing. في spike ولا ما في؟ إذا ما في spike, the cause is either battery depletion, maybe the battery, the patient lost follow-up, now there's no battery. ففي bradycardia, في systole device, it's just there's no battery to do anything. Or sensing issue, over-sensing. The pacemaker thinks that there is no need to pace, فما في spike. هذا اللي we worry about مثلا بالOR. إذا في electrocautery, well, pacemaker will think that this electrical activity from electrocautery is intrinsic rhythm, it will not pace. Spike, ما في شيء. في flat line, والpace is not doing anything. إذا في spike but no capture, so failure to capture, this could be dislodgement. Maybe the lead moved. This is most commonly acutely after the procedure. Yani within up to 6 weeks. If the lead moved, but it used to be attached to the myocardium, but now it's not. It's floating in the ventricle. It will try to pace, but because it's not attached to the myocardium, it will not capture. أو high threshold. الأسباب اللي قلناها قبل شوي في high threshold. مثلا واحد عنده potassium 9, myocytes are not gonna respond to the pacing in the lead. The device is trying the lead the same place, but the myocyte is abnormal, so it's not gonna capture. Next, is it sensing? It's under sensing, seeing the intrinsic rhythm. What are the causes? Maybe it dislodged, maybe it went through and through, and now it's in the abdomen lead. It's not gonna see QRS. Or maybe at the time of implant, everywhere was scar, when R wave was very small, and you didn't set the sensitivity threshold low enough to detect. Oh, it was fine during the implant, but then 10 years later, a patient had MI, and the site where the lead is attached is now scar, so the R wave dropped. Or is it over sensing? But it's seeing things that are not there. An example of that, again, if it dislodges, and it goes to مثلا تنسحب تصير بالannulus. So now it's seeing the atrium and ventricle. So it thinks that there is enough ventricular activation, but actually it's sensing the atrial activation because it dislodged. أو if there is lead fracture, مع الفراكتر يصير في artifact. الارتفاct هذا can be sensed as intrinsic activity. Okay. Are you guys confused yet? We'll go through an example to make it clear. So take a minute to look at this and tell me what you think. Okay, so we have Fail to sense atrium, pacing but not capturing, under sensing. Okay, let's go through the steps we talked about. So is it capturing? Yes or no? No, clearly no. Yeah, you have pacing spikes وما في شيء بعده. ما في QRS. So this is failure to capture. So we go back. So is it capturing? No. Is there a spike ولا ما في spike? في spike. So we already now know that there is probably dislodgement or high threshold. Okay. Next is sensing. Is it sensing or is it not sensing? This is more difficult than capturing. Do you guys think it is sensing? Maybe sensing ventricle. Okay. Not sensing, not sensing. Okay. Yeah, it's not sensing. How do we know it's not sensing? Because the pacing spike. Sorry, go ahead. Yeah. Yeah, because the pacing spikes are the same interval. And ما في شيء صاير underlying. So the device is just ignoring everything happening. So we know it's under sensing because it's over pacing. It's just pacing all the time. يعني whether there is a QRS هنا ولا هنا ولا قريبة من ال pacing spike ما غير ال interval between the pacing spikes. When you go back, is it sensing? So it's under sensing because it's over pacing, right? Causes dislodgement small wave. We got dislodgement here. So when you have, and when both agree in one cause, it's probably the cause. This is an example of lead dislodgement. This is the X-ray immediately post-implant. It's not clear. The patient is obese, but you see the lead coming here. This is the tip, the RV apex. This is immediately post-implant. This is a week later, and you can see how the lead now is advanced away from the RV apex. So it dislodged, which led to undersensing and failure to capture. Okay. Any questions so far? Okay, let's go through another example. 40-year-old, complete heart block, dual pacemaker insertion. You see that? This is the atrial lead. This is the ventricular lead. This is the ECG post. I'll give you a minute to look at it. Capturing and sensing, exactly. How did you know pacing, capturing the ventricle? So how do you know that it's actually sensing the atrium? So we know it's capturing the ventricle because there's a spike, QRS, spike, QRS. But how do you know that it's sensing the atrium? There is synchrony, exactly. Synchrony. Because each P, there is spike, yeah, regular P, there's no atrial pacing. Yeah, because there is synchrony. The pacing spike in the ventricle is following a sensed P with the same interval. So you know the device is sensing the atrial activity. Is that clear? Anyone has any question about this? So when you see ventricular pacing following P waves and the P to the spike is constant, you can conclude that the device must be seeing the atrial activity because it waits for a fixed period of time. This is the triggered activity we talked about. Good. If no questions about this ECG, I'll show you when this patient came for follow-up. This is, I presented the emergency room actually. This is the ECG. I'll give you a minute to look at it. No spikes. Yeah, actually there are spikes. I agree, not all leads, but you see here V4, V5, V6, V3. So V spikes, some leads don't show spikes well, but there are spikes. So there's, yeah, good capturing, but not sensing. Capture under sensing, pacing the ventricle only. Good. Okay, so this is the same patient we discussed. So if I ask you, where is the problem? Which lead is the problem? And why? Atrial, yeah. Exactly. So you see, if you compare to the previous ECG, now, like the previous one, there's always spike QRS, spike QRS, spike QRS. That's fine. But there are no P waves preceding each QRS. In fact, there is association. This is a P, P hina, then hina. They're just completely random. So the ventricle is fine, but now it's not sensing the atrial activity. And when you do the X-ray, the atrial lead dislodged and dropped down to the ventricle. Yeah, AV delay not constant. Bilal is asking what's happening in the second beat. Second beat. That's a good observation, Bilal. Nothing actually happening. It's just the P is following exactly where the QRS is starting. So it appears as if the spike is within the QRS, but it's actually not. It's a P wave buried in the initial portion of the QRS. Good observation. Can we tell it is VVI? Well, VVI is programming. That's a good point. So maybe someone changed the programming to VVI. This would be the ECG. You're right. But assuming you didn't change the programming, this patient just came to emerge. No one changed programming, and now the ECG looks like that. That's why we suspected atrial lead malfunction. But if you change the programming, you just you decided to change it to VVI for whatever reason, then that would be a normal function because you ignored the atrial. Yeah. Good. Any questions so far? Good. Okay, so we'll move on to ICDs. So how do you know if the device is an ICD or not, or a pacemaker? By the presence of this coil. Now, the device itself looks different, but this depends on the company and so on. Easiest thing is if you have this coil, which is thick white material on the lead, you know this is an ICD lead. This is an ICD device. So this is how you know from the X-ray if it's an ICD or pacemaker. What's this device? CRT-D, exactly. So this is CRTD. Why did we say CRT? Three leads. Everyone sees that. So this is the right atrial lead. This is the RV apex lead. This is the LV lead. CRT. And then because of this coil, we said it has the ICD function. So it's a CRTD. Good. What's this device? Looks different than what we discussed. Yeah, subcutaneous ICD. So subcutaneous ICD, I just want to mention this for your knowledge. Just like how we talked about leadless pacemaker, there's subcutaneous ICD, where the ICD in the subcutaneous tissue and the lead is in the subcutaneous tissue. We don't use the venous system. It's a relatively newer technique. Again, advantages, just like the leadless pacemaker, eliminate the need for vascular access. Some patients will not have access because of dialysis or previous lines, so you can do subcutaneous. You take out the lead malfunction issues in the future. There are no risks of pneumothorax and tamponade because you're not putting anything inside the heart. It's just below the skin and fat. These are the advantages. The advantages of the transvenous ICDs are they're smaller. The device itself is bigger for the subcutaneous ICD. The transvenous can pace and can be an ICD, whereas subcutaneous is only for ICD. So you can't do CRT using subcutaneous ICD, at least not for now. Even in patients who are at risk of heart block in the future, for example, the transcutaneous will not pace, whereas transvenous will. That's an advantage. And then, we know the long-term outcomes for transvenous because we've been implanting them since the 90s, but the subcutaneous are newer devices. So just like the leadless pacemakers, we don't know the long-term, but it's an option for some patients. Okay, so ICD interrogation, and this, again, this can be very complicated. What I want you to know are two things. One, a general overview or an algorithm of what to do when patients present with ICD shocks or therapies, and what do EP team want to know if you're on call and there's someone with ICD therapies presenting to the emergency room or NCC. Just like, because we said ICDs can pace and can do defibrillation. So all what we talked about with the pacing testing will apply to ICD, right? Sensing, pacing threshold, and impedance. If it's a CRT device, one important parameter to note is the percentage of IV pacing. As we said, we implant the LV lead because we want resynchronization. So the more we do that, the better for the patient. In patients with atrial fibrillation or PVCs, the percentage of IV pacing might drop. And this is an important parameter in patients presenting with heart failure, for example. And then the last thing is ICD shocks, patients presenting with ICD shocks. So how do you approach ICD shock? There's a patient with ICD shock who presents to the emergency room or the device clinic. The first thing you need to know is whether this shock was appropriate or inappropriate. Appropriate if it's done for ventricular tachycardia or ventricular fibrillation. This is why we implant ICD to start with. Inappropriate could be from three reasons. Could be from SVT. So if a patient, so always think about ICDs the way they're programmed. We ask them to intervene when the rate of the ventricle higher than set number. So So even if it's SVT, it will assume it's ventricular tachycardia and it will deliver shock. So if someone goes into AV NRT and the rate is 200 beats per minute, there will be ICD shock. Is that appropriate? No, because it's SVT. This patient is not going to die from SVT. Similarly, AFib. If you have AFib with rapid ventricular response, the device will deliver a shock. Or it could be technical problem, like lead fracture. We said lead fracture can cause artifact in the lead, which can be interpreted as intrinsic activity. And if it's frequent, it will be interpreted as VF or VT, and it will deliver a shock. Once you reach that stage, this green differential, it becomes a clinical management, really. If you have someone with appropriate shock for VT, then you treat as if there is no device. This is VT, you look for causes. Is there ischemia? Did the patient stop medication? Do we start anti-arrhythmic or do we refer for ablation? And so on and so forth. This becomes, clinical judgment. Similarly, if it's inappropriate, then you make your distinction, and we'll talk about how you differentiate between these three. And then you manage clinically. It's SVT, you refer for ablation, AFib, you rate control or ablate. Don't forget to anticoagulate, and so on and so forth. And then you ask the EP team to look at the programming, because there are, nuanced reprogramming things that we could do to help the device. Because the primary step for the device to determine when to deliver shock is rate. But there are things that we could program to help the device. So for example, if it's a dual ICD, we can ask the device to look at the relationship between the atrial activity and ventricular activity to decide whether to give a shock or not. So in AFib, the atrial activity will be very disorganized, extremely fast. So we ask the device, even if the ventricular rate is fast, if there is disorganized activity in the atrium, don't shock, and so on. But this is really EP-related programming. As a general cardiologist, you need to manage the underlying rhythm like you do if there's no device. Any question about this algorithm? We have a question here. If there's someone with ICD and the patient goes into VT and you want to give the patient the external shock, that's a good question. Can you do that? Absolutely. In fact, what you should do, if you walk in the room and patient is getting shocks awake, the first thing you should do is put the magnet on the device. What does the magnet do to the device? If it's ICD, it will inhibit shocks. It will ask the device not to give any shocks. And then you manage the patient as if there is no ICD, like you manage any VT in the CCU or in the emergency room. So can you give shock? Absolutely. You can ignore the presence of ICD. What happens sometimes, once there's a device, people can be a bit, can get confused about, oh, the device will deliver shock, or let's wait. You just assume there's nothing there, and you manage the code as if there is no device. And if the patient is awake, so sometimes, not common, but sometimes if you have lead fracture, for example, the patient will present with ICD shocks. These are really painful, and the patient will keep receiving shocks. So what you do, you put the magnet on the device, which will inhibit the shocks, and then you decide if the patient needs shocks or not. In the case of lead fracture, patient does not need. So you prevent the patient from receiving multiple painful shocks. Question here, how we will know the initial rhythm, the ICD device? Yeah, good question. So when you interrogate the device will give you everything that happened since you interrogated the device last time. And then so it will give you, let's say you interrogated the device 6 months ago, and now a patient is presenting with ICD shock. When you interrogate the device, it will tell you that since last December, the patient received 3 shocks. And you can go, and I'll show you an example, and you can go to each one of them and see what exactly happened. But acutely, if you walk in the room and the patient is receiving shocks, you have the monitor. So when you put the magnet, you just manage the patient as if there is no ICD. In case of VT storm with very frequent shocks, is it better to put a magnet or let the device deliver it? Yeah, that's a good question, Abdul Mohsen. It's really a clinical judgment. The advantage of putting a magnet and you controlling shocks, you save battery. That's one thing. 2, sometimes patient can have VT, but the patient is awake. The device doesn't know that, you do. So you wouldn't give shock when the patient is awake. You'll give sedation or give amiodarone and wait a little bit and so on. So what I would say is most of the time, the patients in the CCU and receiving multiple shocks, it's almost always better to put a magnet or reprogram the device and you control the situation rather than letting the device does that. Okay, so let's go through an example of a patient who had an event. So this is what you will see. The device will tell you the exact date where this happened. It will tell you what the device thought it was and what it did for that event. So you guys know what ATP is? ATP is anti-tachycardia pacing, exactly. Which means the device, before giving a shock, it will try to pace faster than the ventricular rate to terminate this tachycardia before it gives a shock. So it's painless. So this is what it tells you. It tells you the date, what the type, what the device thought the type is, and what therapy was given. So here it gave ATP, no shocks. These dots, again, can be confusing. I don't want to, this is probably not general cardiology level, but just so you know, just to get a general idea. This is the interval between each QRS and QRS. Each dot represents VV interval, the time between 2 ventricular events in milliseconds. So what you see here is fast ventricular rate, about 300 milliseconds, which is 200 beats per minute. When you do these more often, you translate milliseconds into beats per minute quickly. But I can tell you this is 200 beats per minute. You have tachycardia, fairly regular tachycardia, because the VV interval is same. And then here it says detection. So the device detected tachycardia. It gave burst ATP. You see how it's faster. And this terminated tachycardia. Because now the ventricular rate is slower. The longer between VV, the slower the rate. And then you look at the EGMs themselves. This is how the device is seeing them. These are similar to QRSs on ECG, but they're not QRSs because these are from the lead itself, from within the heart. And the benefit of this, you see the morphology. So this is the tachycardia. This is TP, so ATP, pacing faster. This is when it terminated. So the benefit of this is now you can compare the morphology. Because remember the algorithm, we said, if there is ICD shock, I need to determine if it's appropriate or inappropriate. Is it VT or not VT? How do I tell? Well, here, if I ask you, is this morphology similar to this or different? This is during tachycardia. This is sinus rhythm. What do you think? Okay, we had different votes. Similar, some people are saying different. This is a clinical judgment. The point is not to teach, but just the approach. I would say this is fairly similar. I'll show you an example of different. It goes up and then down, and then there's this slurred thing, up, down, slurred thing. So if the morphology is same, doing tachycardia and sinus, what does that tell us about the tachycardia? Is it VT or SVT? Inappropriate, exactly. Yeah, so this is inappropriate. It's not VT, because why would the morphology same? And then if it's inappropriate, is it SVT or AFib or technical problem? Well, it's not AFib because it's regular. It's SV, and it's not technical problem because there was tachycardia. SVT. Yeah, exactly. So this is how so this patient had inappropriate therapy because of SVT, and then you manage the patient for the SVT. So beta blocker, you refer for ablation, and so on. Okay. I'll give you another example. Again, this is the date. This is how it was interpreted as BF. This is what it gave. It did ATP once, and it gave a shock. So again, this is tachycardia around 200 beats per minute, regular, detected by the device, gave ATP. But then this induced tachycardia again. Actually faster than the first one. So the device gave a shock and went back to sinus rhythm. If you find this a bit confusing, don't worry, this is not general cardiology level. I just want you to get used to the general idea so you know what we look at in EP. And then you look at the EGM. So you see how this is the tachycardia. Is this morphology different than this? These two beats, different than this? Yes or no? Yes, clearly different. So is this appropriate ICD shock? Yes, exactly. So you know this is appropriate ICD shock. Now you manage the patient as VT. You discuss amiodarone, CAF, electrolytes, ablation, and so on. So good. So this is essentially what I think you need to know about ICD interrogation. As I said, this is really EP level, but when you admit the patient, you need to know that this is what needs to happen. The big picture, is it appropriate or not? How do we know in general terms? And then you manage the patient. Good. Last thing I wanted to discuss is the preoperative device management. You guys get called often. Someone has a device, needs urgent surgery. What do we do? And there are two questions before I show you the algorithm. Why do we worry? We kind of discussed that briefly, but why do we worry about surgery and devices? Why is it a concern? Arrhythmia? Not really, but arrhythmia we worry about in any patient. Electrocautery, oversense, exactly. Cautery, good. Yeah, we worry that they will use electrocautery in the surgery. Electrocautery is electrical field, and the device might interpret this as intrinsic activity. So what would happen if a patient has a pacemaker and misinterpret electrocautery as intrinsic activity? What would the device do? If it's a pacemaker, it will inhibit. Exactly. It's a pacemaker. It will think that there is intrinsic rhythm. It won't pace. And if the patient is dependent, this will lead to asystole. And if it's ICD, you might be interpreted as VT or VF, and it will deliver shock. So that's why we worry. We worry that in pacemakers, we worry about inhibiting pacing, which leads to asystole. And ICD will worry about inappropriate shocks because of oversensing. The next thing you need to know is what happens when we apply magnets to pacemakers and ICDs. So what happens if you apply a magnet to a pacemaker? DOO, exactly. So it will pace, it will not sense anything. It will just keep pacing, asynchronous pacing or VOO, DOO. Good, this is for pacemakers. What about ICDs? Will not shock. Exactly. It will inhibit shocking. Good. Switch off. Yeah. Exactly. This is going to be relevant to the algorithm I'm going to show you. So this is one of the algorithms you could use. If you have someone going for surgery with a device, you ask yourself, can we access the device or not? Meaning, if the surgical field is around the device, or cardiac surgery, you're not going to be able to apply magnets. But abdominal surgery, you can. Yeah, this is one quick question. So if you can access, yes. Are they going to use electrocautery? If no, then you say there's really no need to do anything. Just keep a magnet close by. If anything happens, just put the magnet on. Okay, if you can't access it and they are going to use electrocautery, then you have two choices. You either apply magnet or reprogram the device to VOO. Some people, you know, if it's really an emergency, you don't have time to call the EP tech to come and so on, you can just apply magnet. If you have time, probably better to reprogram. Magnet طاحت مدري إيش, you know, it's just more stable. So yeah, if it's not accessible, you cannot apply magnet, then you ask, are they going to use electrocautery? If yes, reprogram the device. If no, then you say, well, we can just do nothing and just go proceed with surgery. Or if you want to be safe, reprogram the device. It's a clinical judgment. If a patient is pacemaker dependent, it's a place where it's difficult for them, if anything happens, to call a cardiologist or electrophysiologist, and maybe it's just easier to reprogram. If it's in a big hospital, easy to get people around, and patient is not pacemaker dependent, then you can say, go ahead. No need to do anything. Access device, meaning can you apply magnet? Yani the surgical field is away. And if you're doing thoracic surgery, you're not going to be able to put a magnet on because this will be sterile field. But if they're working on the abdomen, you can access the site of the device in the chest to put the magnet on. Any question about this algorithm? EMI is electromagnetic interference, which essentially means, are they going to use electrocautery or not? Yeah, there are many details. Does it depend on the site and distance of cautery? Yeah, there are really many details I didn't want to go into because it can be confusing. This is the big picture. It depends on the type of electrocautery. Is it unipolar or bipolar? It depends on the vector. If you're working on bladder, for example, where the electricity is actually not going to go through the heart, then probably doesn't matter, and so on and so forth. But so it can be, there are many details, but this is the big picture. If you do this, you're safe. You might be overdoing it, but you're safe. Hassan or Hassan, again, please. You mean algorithm? Okay, good. Any questions? I think actually this is it. If you have any questions about anything we discussed or anything about devices in general? Okay, I think we're good. Excellent. Good luck. Yeah, assalamu alaikum.